Okay, so in our last class, we were discussing about sustained release formulations, how to prepare formulations which can be extended release, what are the different formulation types we discussed. And I will go for the same chapter for some time. Yes. I think I will share my screen as well. Then we will come to our discussion. So in our last class, we discussed about hydrophilic matrix system. Okay, and subsequently we were discussing on hydrophobic one, where the drug is not really water soluble things, and then we coming on insoluble polymer matrix. Insoluble polymer matrix is a insoluble material which is controlled by pore size and number of pore and the tortuosity, like a sponge behavior, right? It is not going to be soluble. And then I think I'll switch on my screen here. Okay. Yes. So I think my screen is shared. Can you respond? I think no. So we are going to discuss today on soluble matrix. We discussed soluble matrix and insoluble one. Soluble and insoluble matrix, what is the difference? In case of insoluble matrix, the drug is actually not dissolved. They are in particle forms, and there is a polymer which will also not get dissolved. So even if water is coming in, nothing is happening, only water can percolate through the pores and the drug molecules are coming out. So size will remain unchanged. Okay, polymer is not going to alter its shape or size, only drug is releasing. So water is going into the pore. So pore is very much important when I'm talking about insoluble matrix. Soluble matrix, we are using hydrogel. We already talked about that. I will go to the textbook as well. And the last one, what we could not discuss in our last class, is actually based on membrane-based approach. Now, membrane-based approach are of two different varieties. Formulations can be done. One is your formulation. The tablet is coated with a membrane. Otherwise, there is no much difference. So this is a membrane. And the water can come inside, water is coming inside and it is dissolving the drug, and the soluble drug molecules can diffuse. Please remember, nothing is broken. So here membrane is stable. Please listen to these aspects. Membrane is stable, water goes in, drug is dissolved, and the dissolved drug or drug in solution is diffusing out. These kinds of approach is known as membrane-based sustained release formulation. Am I clear? So here you are having the drug molecule core. There is a above coat. The membrane allow water to come in, so water molecule can go inside. Once water is coming, please remember the steps. The water goes inside, it is dissolving the drug, and the dissolved drug molecules can diffuse out. So diffusion is the rate limiting step because membrane is permanent. So you understand, that it is only allowing solution. No particle can come out. Particle things are not released. So these kinds of approach are known as membrane-based approach. The last one approach for sustained release formulation in theory is coming from osmotic release. I'll come to the textbook later on. Osmotic release. What is this? This is also very interesting, but there is some small differences over here compared to this one. The first thing in osmotic release is that the membrane is there and the drug is also there, but membrane is having some perforation. Your membrane is having some pore, so it is already some micro size perforation is there in the membrane. So what is happening over there is somehow different from the osmotic release, is different from membrane based release. What is happening? Water is coming in. That is always obvious, no issue. Water is building pressure, so osmotic pressure is increasing. And now there is no diffusion of drug. Please listen, there is no diffusion of drug. Once the molecules are dissolved, membranes can break out, releasing the compound. So osmotic pressure is created because of the water inlet. So here the principal, then if I ask you what is the principal difference between earlier one, membrane and osmotic release, the very simple difference, if you see the mechanism involved. So this is membrane. Why I am discussing the difference? Because normally we need to have the questions which are very much specific, right? And this is osmotic release. Mechanism. First one, water in here, yes, water coming in here also. So this first step is always common. In membrane, is there any micropore? No. Here, micropore is there. So I'll say micropore. Here, yes. So actually your membrane is little porous. Then dissolving, dissolution. So water will come and it will dissolve the drugs. Here also dissolves the drugs. So dissolution is there. Fourth one is diffusion. So here, in case of membrane, what will happen? The drug dissolve will come out. So diffusion is yes. Here, drug dissolve will not come out. So diffusion is no. So find the basic difference. What will happen then? The last one is release. Whole thing is not broken down. So release is controlled, right? It is not completely broken. Structure is remain as such, so it is controlled. Here, as the water is coming out, these molecules, not diffusion. Don't say it is a diffusion. It is like a physical tunnel. Okay, diffusion is a membrane-bound gradient process. It is like a tunnel. So dissolved molecules are actually coming out through the tunnel, nearly breaking. So there is no diffusion, but it is a physical passage of the molecule across there. Okay? So here control is little low because pore size is allowing the molecule, dissolved molecule, to cross it like a tunnel kind of things. So that differences makes a big changes when we are going to have osmotic based control release delivery and membrane based control release delivery. So this is the principal things. I will come to the text so that I can have a quick discussion on this. So in our last class, we talked about insoluble polymer matrix. My screen is visible, I believe, strongly. So here, insoluble case, you are having inert matrix. Insoluble polymer matrix is controlled by the pore size and number of pore and tortuosity of the matrix. When I'm going to membrane one, then drug is concentrated in the core. must transfer a polymeric membrane or film, which is going to control the release rate, that is the membrane one. Important criteria is that drug should not diffuse in solid state. So once it is dissolving, the first case, the first example is the membrane I am talking. However, membrane controlled delivery system may be more likely to be in the form of pellets and monolithic system. What is that? I will come later on. And then we are talking about osmotic. Osmotic pump systems are another form of membrane control. Here what is happening? Difference between an osmotic pump system and a classic membrane control system is that for osmotic pump, only one-way diffusion process is required. Please understand the differences. You see, in osmotic pump, what is happening? Drug core is coated, so this water molecule coming in, you see, and then dissolving, and there is a pore. Through pore, it is coming out, not diffusion. Okay, it is increasing pressure, is like a bursting it out. So drugs can actually get released. That is the only differences between osmotic system and membrane-based system. Okay, am I clear? So when I am going to coat with a membrane, the diffusion is the primary driving force. So this is first one, this is second one, this is the third one. Now, in case of membrane control, I am studying that the membrane control drug delivery system is more likely to the form of the pellet than monolithic system. I will speak on that a little bit for 2-3 minutes. So in case of membrane, there is something new things you need to understand. What is that? When I am talking about membrane kind of things, membrane is understood, diffusion is the controller. But then we are telling about monolithic versus particle. Now, how are they different? Monolithic means this is your core. Drug molecules are there and only one coat, outside coat, polymer coat. That is monolithic. And when I'm talking about granulated, granulated means not like that. Granulated means it is made up of not powder, it is made up of granules. Granules are itself coated. Granules are itself coated, please understand. So granules are all coated and the whole core is actually made up of granules. Okay, here just a powder core, normal tablet, whatever you have seen normally, these are powder. But here it is made up of small granules. Now what is the advantage here? One advantage is definitely there. The first advantage is that if I am using these kind of tablets, monolithic tablet, and we are transferring this drug through gastrointestinal tract, one problem is that the drug is not dissolved, right? It is solid. So maybe nothing is released, one problem. Or second thing is that maybe the membrane is broken or somehow teared, then it is known as everything released or everything released. That is called dumping. Dumping frequency is very high when I am going to have these kinds of monolithic membrane module based delivery system. Am I clear? Dumping means all drug is released together. A problem sometime. Or because this tablet is big enough, they are not dissolving, they are not degraded, nothing is released here and it can be extended. So this job is not fulfilled. But here, what is the happening? One advantage in this kind of formulation is that because even if the membrane is broken, what is actually released in the stomach is not the drug. The granules are released. And granules themselves has some coating. So even if something is released, all drug will not be released. Drug is not released, granules are released. So all drug is not coming into your blood. So wastage of medicine, maybe it is degraded or the drug is completely loaded. So maybe overdose chances is low. Dumping frequency, dumping problem is also low. So am I clear? So when I am going to have these kinds of monolithic versus granular formulation of membrane-based system, granular formulations is preferred. One advantage is that it is having all the granules are itself coated. It can give prolonged time. And second thing, the negative effects or some situation when the drug is not broken or completely broken, both the situations can be avoided. Am I clear? Even if it is completely not broken, drug will not come. So here always either high or low possibility. But here it is always moderate, because something, even if it is broken, all drugs will not come. Dumping is less. And if it is something is releasing, some drug will definitely come into the system. So not like this. So this advantage makes granular membrane-based system of drug delivery more preferable than the other one. So basically, I am going to conclude this sustained release drug delivery systems here in this class, because further we are not going to discuss on this. So osmotic system, how is it working? What is the difference? What is the principle we are talking about? Okay, so this is fine. There will be further more differences on gastric retention when I am going to have gastro retention properties. There is some other things we are not really going to discuss, how they are controlled. You see, this is the concept they are going to take overview of the research areas where you are going to think about. So stomach content, we are going to have a tablets. Now the tablet can be actually expanded, okay, when it is going, because they're taking more water, it will be swelling in size. And this approach can actually give us the stages, how it is going to pass through the stomach and what advantage we can put over there. And there are some form, I will not go in details simply. So we'll go on how they normally work on the gastrointestinal delivery system. You see, I cannot have the drawing here. So basically, gastrointestinal things is that drug core coated with delayed release membrane. So we are going to have a membrane. So I want to protect the drug not from releasing into stomach. I want to protect it. So there are multiple ways we can do. We are coating it first. Then you see, exposure to correct pH dissolve the coating. This is the most widely used formulation type. The coat will dissolve. So for example, the coat is stable in low pH, but if it is go beyond 7 alkaline pH, the membrane is unstable. So maybe you can make something proteinous coat also, which is not going to be soluble in alkaline conditions. So when it is reaching colon or maybe in small intestine or larger intestine, the pH is not acidic, right? It is more alkaline. So it will be dissolving the coat, drug is released. So they are actually protecting from releasing in stomach. This is one mechanism. The other mechanism rarely used, but definitely more important nowadays, is bacterially triggered colonic targeting. What does this mean? So these kinds of coating is such a way that in our gut there is a group of microorganisms which is releasing different kinds of enzyme. Maybe they are using protease, they are using in some time lipase. That means those enzymes are not in stomach. So when I'm going beyond in colonic area, there is a colonic gut microorganism. They can secrete different kinds of enzyme, and those enzymes can actually break down the membrane. So enzymes actually generating hole in the coating. So until now, drug was stable, nobody can actually break down, but finally drug molecules are coming and getting released. So this is actually gastric emptying strategy or gastrointestinal delivery that can be done, or maybe in colonic drug delivery also the same thing can happen. Okay, you see, they are going to make some ethyl cellulose based membrane, and they can be colonic bacteria can actually do this degradation. Okay, so when I am going to have this kind of resistance molecule where specific group of bacteria can produce some enzyme and break it down, that can also give you the colonic drug delivery approaches or maybe strategy what we can be actually considering. So basically with that one we will be closing our discussion, colonic delivery and stomach gastric delivery, gastro-resistance coating. Gastro-resistance coating means it will not work out at low pH. It is only working out above pH. Okay, so low pH but are soluble at high pH, somewhere in between 5 and 7, right? So if I'm having such kind of polymer, it can actually do the job, and that is the mostly widely used to protect it. That is the one approach we are talking about. And next one is colonic delivery. With this one, we are concluding this chapter. And now, okay, I'll show you what we are going to discuss today. Basically, we'll be primarily discussing now on, yes, parenteral drug delivery system. So we have already learned about capsule, we have learned about tablets, we have learned sustained release tablets or capsules. Now, from now onward, we will be focusing on parenteral drug delivery system. So today we will be just classifying what are the different kinds of parenteral deliveries are there, what is their purpose, what is their intention, why they are used. Okay, and how is they are going to be useful. Parenteral drug delivery, what does it means? First of all, let me tell you, enteral means if it is going through mouth. So parenteral means we are going beyond mouth, we are not following that. So that means anything, by definition, anything except we are taking through mouth is known as parenteral. It is not going to be ingested. Then you may say, sir, if I'm using some cream, is it not parenteral? Yes, by definition it's true, but most of the day now people actually think parenteral means through injections, even if by definition parenteral also includes the cream, patch, okay, or gel we are applying on topical, we are putting on ear. All those things we can actually refer as parenteral delivery. But basically parenteral means we are talking mostly of the form of injections. Now question comes, okay, injection is, we all know very well, there are some, but there is some specialized injections varieties also we'll be talking about. So basically injection can be applied, and this is a systematic, not I'll say systemic, rather systemic delivery. Systemic means throughout the whole body together. And most of the injections can be given on vein, so intravenous, okay, subcutaneous, intraarterial, intramuscular. These are the different forms of injections volume. Normally, the volume we are injecting into individual can be some ml to some few liters also. ml is mostly you are going to take those injections either intravenous. Okay, most of the things you are taking intravenous. Some of the things we will be taking subcutaneous. Some very rare, but it is also there some kind of intraarterial injection and intramuscular injections. Now basically these doses are normally within 1 ml to few liter. Few liter when I am going to give, that is called transfusion. Okay, normally we use some dextrose saline for people, we can use these kinds of delivery. Otherwise these forms mostly take within some 1 ml to 2 ml or even less than 1 ml is injected through these routes. Now what is the difference? They are also different, right? Intravenous means we are going to put on or putting the drug in vein. Vein is more easily available, right? We can easily identify for a healthy individual, right? So for example, in your hand also, you can find out, locate the vein, and the drug can be injected directly, intravenous. Subcutaneous is also done. It can be done on the skin, below the skin. So that is, I'll tell you, there is a difference between their injection modalities. Some picture is also there. So subcutaneous means below the skin layer. So epidermis layer we are going to inject. Intramuscular means we are going to inject into muscular tissues. Why we inject like that? One reason. In case of how much blood is there, right? When I am going to put in intravenous means immediately all the drug coming into blood. When I am going to have intra-arterial system, that is also there similarly, but there is one small difference. Intra-arterial will only inject if you want to have very quick delivery to a specific organ, because I know vein will go through whole body and then it will come into circulation, right? But arterial systems will actually deliver it. Vein is actually, you see, this is your heart. Normally I'm drawing, this is your vein, sorry, artery, which is carrying the blood, and vein is returning the blood. So there is one small issue here. If I'm injecting something in the vein, it will actually go into heart first, collecting, mixing everything, whole blood, and then coming into your organ. So basically the route is actually little longer, and some drug will be already distributed to all other parts. But for example, if I know this artery is going to this organ, for example, this is going to this liver, for example, I know this artery is going. And if we can, this is actually really difficult, if we can inject drug here upstream, what will happen? Most of the drug will actually go into this organ. So intravenous is very common, intra-arterial is rare, but it can be more useful when you are going to treat some specific organ. Difficulty is that finding artery very close to your body surface or skins are not found in most of the time. Okay, so in case of, if you are going to inject some drug, in case the artery is available or you can penetrate through this, then arterial drug delivery can be given. Even some injections are made which are actually intracranial injections are there. We can have some injections where we are delivering the drug into spinal cords. Okay, that kind of deliveries are also there, but they are very critical and we need some expertise on those domains. So basically that is a different issue. First issue is that why we are looking for this parenteral drug delivery, what should be the criteria? So first purpose is that it is very fast, quick delivery, which can be delivered in 1 ml, just small injection, or sometime which can be delivered through transfusion. Okay, maybe for example few liter. So for example, this is your saline bag containing dextrose and NaCl. Sometime what happens, the doctor can actually inject the drug here itself. So your drug we are injecting directly here. So what will happen? Slowly you are adding the drug into the body, right? Because it will go over a few hours. So one approach is that you can directly add all drug if it is small volume. If it is a concentrated drug, you can dilute it, mix it with the transfusion bottle, and it can be injected. Why this kind of approach is good? Because you can have a control, right? How much drug I will allow it, I can have a valve, we can control. So here also we can have some, we can see the patient improvement, we can release the rate, increase or decrease the rate, how much is going into the systemic circulation. So here, in case this kind of approach, we have more control on that. Second thing is that it is very specific, so it is going to your bloodstream most of the time, so loss of drug is really not there, or loss of activity like in stomach it can happen, na? These are not there. So these are the all advantage. It is very fast, it can be giving you result within defined time, loss of drug is not there, Metabolism is not going to happen in case of, for example, fast pass metabolism we can avoid. They're all good things. Some bad things are also there. The first bad thing in this kind of drug is that you cannot have very much control on this. Whatever I'm injecting, once it is injected, you have very less chance that it can be reverted back. So drug injected is going to give you action very quickly, within minutes, and the drug can be eliminated also very fast. So when I'm injecting something, I can have quick response. So drug normally profile will be very quick going up and then slowly coming out, because the drug injection site, the whole drug is coming at the same time, nearly zero time, only the elimination happens. So here we cannot prolong the drug action time period. This is only one problem. So we cannot prolonging the therapeutic dose is a challenge in case of these kinds of drug delivery system. The fourth one, because it is normally distributing throughout the body, so maybe in your site of action, drug concentration may not be always sufficient. Mostly this is the problem when you are going to go for intravenous injections, right? So these are the things we need to understand, and I will come to your textbook portion for some amount of discussion, though it's very simple anyway. I think here, yeah, this is chapter 36. Please keep a note of this. This is parenteral drug delivery we are talking about. Okay, these are the very basic things. So what is parenteral administration? You understand, which is not in gastrointestinal tract. Reason we are choosing parenteral. So it is, you see, it is often simpler and much cheaper to prepare medicine such as tablet and liquid. You understand? So from drug manufacturing point of view, the parenteral is not really good, because you need to be more careful when I am preparing parenteral. Many precautions are there. We'll talk about them a little bit later. The first very precaution is that whenever I am using a parenteral, it should have some quality criteria. I can specify right now, maybe later on we can discuss further. What is the minimum quality of the parenteral formulation? What cross check you should have? First cross check is that drugs should be completely dissolved. Completely. It should not make any precipitation. It should not make any, when I'm injecting, for example, this is a blood, right? Fluid. And when I'm injecting something, some different solution and different solvent, if I'm injecting, and if the drug is getting precipitated, for example, the drug is little hydrophobic, this will be causing very much problem. The first problem is that if the particle is agglomerating, it can actually block many capillaries. You understand? It will be finally channeling out further small capillaries. So these drug particles, it should not form any particle. Otherwise, it will make a clogging of your blood vessel, and which may lead to death also. So this is very important criteria. Dissolution of the drug is very important. Second criteria is that the drug must be sterile. Sterile means I'm talking about pathogen, microorganism, virus, whatever. Completely particle free, completely pathogen free, it must be there. So that means sterility is a problem. I can open a tablet and then I can consume. Even if 5 minutes I'm keeping my hand, nothing is going to happen. Some bacteria will go with the tablet, nothing will happen. We're taking so many foods, right? They are not sterile. But injection, it must be. Because if there is some pathogenic microorganism is going into blood, it can be fatal. So sterility of the formulation is very important when I'm going to have formulation of parenteral. And third one is not only this, toxins and other impurities. Not only bacteria. Bacteria anyway you can sterilize, you can put UV sterilization, you can autoclave. those things will be protecting you, right? But toxic and other impurities, so for example, we are preparing some things and it is having a impurity of some amount of magnesium, or maybe some impurities of some other rare earth elements, or it may have some bacterial toxin. Bacteria is not there, but maybe some enterotoxins are there, some toxic materials are there. You must be removing those toxins, removing those impurities. So it must be absolute quality checking is required whenever I am making any parenteral. That's why parenteral formulation is always much costlier than your tablet, right? So for example, if I'm taking a paracetamol tablet and I'm going to have a paracetamol injections, I may expect the cost will be higher in case of injection. The reason is that the maintaining sterility, we need to have injection, we need to have the syringe sterile, we have to injection water should be sterile. Many times injections are coming into a powder form, okay, sterile powder. Then we normally have, so for example, this is the injection, sometime we can have injection vials or container containing the powder, okay, and they're also giving you water for injections, right? Small vial of 1 ml, 2 ml. This is sterile water. Not only sterile, it should be free from pathogen, it should be free from any particle, it should be free from toxin. This water, sealed vials is there. What is you are supposed to have? You are normally breaking it out, taking the water and mixing it again using injection. Then you are reconstituting the solution, and then you are taking it out and injecting. So this kind of water is called water for injections. And this is the powder preparation for injection. Both should be sterile. This is one way. Second thing is that some injection is already constituted. You need not do anything. It is already in solution form, already prepared in solution. You just break out and take in, inject and inject. That's all. So this is a ready-made one. In both the cases, these precautionary measures must be included when we are formulating. So these are the primary things. Fourth thing is that many times when I'm injecting something, so for example, this is the blood vessel and we are injecting something here. At the site of injection, you see, I'm having very high concentration of drug for some time. When you are injecting this time period, of course, you are injecting within 5 seconds or 10 seconds, not a big time gap, but locally there can be one edema formation because concentration of drug is too high temporarily, because in my vein blood flow is not very high, okay, locally. So this may cause some inflammations or swelling. Normally you have seen site of injections, you may feel pain, inflammation and swelling, which can happen when I'm going to inject using these kinds of needle based approach for injecting something. The other option is that many times nowadays people use a catheterized tubes. So they do not inject like this. What they do in hospital also, they do like this, continuous drug delivery. They do not inject every time. So they put a channel here. And this is having a catheterized flyer. And of course it is capped. So when the doctor is coming to inject you, he will open this and inject it directly. So a temporarily channel is already created. So what is the benefit here? Here, the channel is opening in the main blood stream little bit. So that means blood flow is very high here. But when I'm injecting on this site, it is very close to the wall, right? Wall of your vein you are injecting. It is not really delivering it properly. Advantage here is that blood flow is high. So anything I'm injecting, it is quickly getting diluted. And so these kinds of reactions can be avoided when I am injecting through these kinds of channels or catheter, normally we are saying. So here these kinds of issues are definitely there, even if it is good enough for a drug delivery. So these kinds of problem can still be there. I'll come to the textbook so that I can just correlate whatever we are talking about. So these are the things we need to know. Okay, drug molecule itself would be rapidly broken down in GI tract. Okay, this is advantage. These are highly localized effects can be there. Intraocular injections to treat eye, I told you. Similarly, we can have injections when we are going to give intra-arterial injections can be there from some steroids. Articular injections can be there. Spinal cord, some injections can be given. Okay, sometime you can see cerebrospinal fluid also delivered drug we can have in spinal column we can give. So depending on what kind of purpose the drug have, what is the site of action, some can be given, but they are not very common. Okay. Now we can have some formulation which are going to give in intramuscular injection. Intramuscular injection is given for keeping it for long time. When I'm injecting something in a muscle, muscles are not having so much blood vessel here. Okay, so the amount of capillarization or perfusion is low in muscle. So when you are injecting something in muscle, it takes time to come into the blood. So actually you are also increasing the time if you want to have intramuscular injections. Okay. Now how you are going to inject? There are many varieties. As I told, you can have some 1 ml injections to sometime infusion we can do more control rate, and maybe few liters we can inject, maybe 1 liter infusion bag or 500 ml infusion bag we are doing. So this can be done. Medicine administered intravenously via a central line become rapidly diluted. I told you, right? We can put some catheterized connection drip we can put. So we can connect it into the main central line and we can release it. So these kind of injections can be really more easy. Intra-arterial administration is also there, but very rare. I told you, like in liver cancer, they can try to put the drug before upstream of the liver in artery. Why? Because that will deliver the whole drug into artery. That is the only one advantage we can have. So these kind of situations, people may go for intra-arterial injections. Intracardiac injections are also administered. You see, a common example being the aqueous solution of adrenaline, right? Directly into either the cardiac muscle or the ventricle of the heart. When we are going to do? When life-threatening emergencies, okay? So this can be done in myocardial infarction or someone is having circulatory collapse. That time only in emergency, these kind of injection, very rare, of course, not very common, is also taken. Otherwise, this diagram I want to show you for the different route of administration for just 1 or 2 minutes. The differences. I told you there are 3 different varieties. One is intramuscular. You see, they're straightly injecting the needles to the muscle. Okay. So it is 90-degree angle we are injecting normally. Then we are having subcutaneous. Subcutaneous is below the dermal layer. So here you are having the subcutaneous tissue. Little here the blood circulation is comparatively higher than muscle, but low than when I am talking about the dermal. So intradermal. So inside the dermal layer of the skin, the drug can be injected. So you can see. So angle of inclination can be also different. Amount of the drug we are injecting can also be different. Okay. So intradermal volumes can be, for example, up to 0.2 ml can be given by this route. So very small amount we can give. And absorption from the intradermal injection site is also sometimes be slow. Anyway, I think I will discuss about those injections in detail and how the formulation is made, sterility, container. Those aspects we can discuss in our next class. I think some people have already left. I'll take an attendance once again.